Good evening, ladies and gentlemen. Today we are going to look at acute diarrhea. Welcome to our PED lecture series. My name is Dr. Isaac. So in the introduction, let's define diarrhea, which is frequent loose or watery bowel movements that deviate from the child's normal pattern. Diarrhea may be accompanied by anorexia, vomiting, acute weight loss, abdominal pain, fever, passage of blood in stool. If diarrhea is severe or prolonged, dehydration will definitely occur. And in absence of dehydration, chronic diarrhea usually results in weight loss or failure to gain weight or even failure to thrive. Diarrhea is a very common concern in children, and if you combine diarrhea and dehydration, these two cause about 1.2 million deaths in a year throughout the world. So let's classify diarrhea. Based on the duration, you can have acute diarrhea, which lasts within 14 days, persistent diarrhea, which runs from 14 days to 21 days, and then chronic diarrhea, that is diarrhea that goes beyond 21 days with a known cause of the chronic diarrhea. If we classify based on the consistency, you can have watery diarrhea and then bloody diarrhea. If we classify based on the mechanism of the production of stool, you're going to have watery diarrhea, which gives us two types of diarrhea, that is osmotic and then secretory diarrhea. And then the bloody type will give us two more, that is invasive and non-invasive, as we shall see the details in the following slides. These are slides showing watery diarrhea and consistent with some particles, and you see that there is no blood. However, when you look at this invasive, you realize that it is blood stained here and then even in this slide. In the pathophysiology, generally, we explain it based on the mechanism of production of this diarrhea, and it includes osmotic, can have secretory, then you can have inflammatory, you can have malabsorptive, and then in explaining the details, in osmotic, from the word osmotic, you have the presence of non-absorbable solutes. Yes, for example, sugars that have been taken through carbohydrates, they accumulate in the GIT. When they accumulate, there is generation of the graduate and then the absorption of fluids from the surrounding into the lumen, bringing about diarrheal illness. And mostly, if the individual fasts, within 3 or 2 days, the osmotic diarrhea will stop. But in secretory diarrhea, there is active secretion of fluids into the GIT and mostly results from substance like toxic bacteria that increases the secretion of chloride ions and water into the intestinal lumen. Secretory diarrhea does not stop even with fasting because there is a need to clear the toxins. And then in inflammatory diarrhea, there is destruction of the mucosa, intestinal mucosa. So when this intestinal or GIT mucosa is destroyed, and then there is ineffective absorption, and then there is resultant outpouring of plasma, serum proteins, blood and mucus, and all that into the GIT content, contributing to its increased bulk and fluid content. So in malabsorption, and this it can be from osmotic or circulatory mechanisms, but the result is decreased absorption of nutrients, any GIT contents that have been taken in. And with the decreased absorption, you're going to have accumulation of these contents, and then you have also increased speed of transit of these food particles through the GIT and decreased absorption. So because of increased transit through the GIT, there's bulk and hence increased stool or bowel movements. So let's classify the etiologies of diarrhea. We have acute causes or the causes of chronic diarrhea. So in acute diarrhea, you can have gastroenteritis, inflammation of the GIT, you can have antibiotic use, you can have food allergies, you can have food poisoning, and also viruses, mostly rotavirus causes acute diarrhea. And then for chronic diarrhea, most times there is an identifiable the cause. For example, dietary factors, inadequately cooked food, and this food is taken continuously. You can have infectious like celiac disease. Remember, in celiac disease, there is the GIT is sensitive to the component contained in flour. Therefore, if this wheat flour is used for making any on a food like bread, chapati, the person will definitely have diarrhea chronically until they stop taking the inciting factor or the causing agent. Then inflammatory bowel disease due to the ulceration of the mucosa and hence the increased dumping of proteins, plasma, and so on into the mucosa. Chronic diarrhea can also be caused by anatomical disorders and disorders that interfere with absorption of the GIT. So in your body, you should be able to differentiate between secretory and osmotic diarrhea. One, if you base on the consistency, in secretory there is active secretion, and therefore most times it is fluid in nature and it's not alternating. However, the consistency in osmotic diarrhea, sometimes you're going to have liquids alternating with semi-solids. And then when you look at the quantity, in secretory there is abundant quantity. And you have more than 15 loose motions per day. In osmotic, there is less abundant in quantity. And then when you look at the state of the child in secretory, because there is increased loss of a lot of fluids, the child will appear lethargic. They quickly get dehydrated and then also get metabolic acidosis. And the child appears with high-grade fever and sick looking. However, in osmotic, the child has good general condition. They rarely lead to dehydration. However, mostly there is one prominent feature which is periannual erythema that can occur. And the clearest example is viral disease, that is rotavirus, that causes the osmotic diarrhea. You will also be able or required to know the difference between bacterial presentation and parasitic presentation of bloody diarrhea. All these bacteria and parasites, they all cause bloody diarrhea, but the presentation will be different in the following ways. In bacteria, the motion has a lot of blood and there is high grade fever and the child is sick looking. Whereas in parasitic like amoebiasis, there's loss of appetite, the child is febrile, vomiting may be present, and the area has little amount of blood-like stray or spot. That is one. Then the other one on physical examination in bacteria, because the child has dehydration signs together with metabolic acidosis, and then you have features like abdominal pain, irritability. In amoebiasis or parasitic infection, the child mostly is okay, but there is a big abdomen because these parasites are in the abdomen. There is mental apathy and the child is not sickly looking. We have already highlighted the example. Here we have shigellosis and here we have amoebiasis. Some of the causes, we have the infectious and non-infectious. So the infectious causes related to the GIT itself, you can have bacteria and parasites. Infectious causes that are not directly related to the gastric mucosa or GIT, we have otitis media, urinary tract infection, pneumonia, bacterial meningitis, or other systemic infections. Now, let's look at non-infectious causes. We have dietary disturbances like overfeeding, food allergy, starvation. Then you have toxins like antibiotic use. These are non-infectious, remember. Iron salts, excessive intake, and then medicinal teas or infusions that are given. And then immunosuppressive states like cancerous states, and then genetic disorders and HIV. And then endocrinopathies like hyperthyroidism, hypoparathyroidism, and diabetes mellitus can all bring about dehydration. These are some of the causative agents. In osmotic diarrhea, you can have rotavirus, norovirus, normal agent, adenovirus, rhinovirus, then also cryptosporidium and GL. Remember, ladies and gentlemen, in case you need these slides, you can inbox me, you can reach me via my email and have them. Secretary causes or agents that are identified to cause secretary diarrhea, you can have Vibrio cholerae, Clostridia perfringens, Clostridia difficile, E. coli, Staph aureus, Shigella, and rotavirus. Then for bacteria and then parasites that cause invasive diarrhea, the list is there, and those that cause non-invasive diarrhea are there. Investigations for stool, you can do serious stool analysis, neutrophilia in fecal mucosa, pH can also be done and identified, and then the stool culture and then rotavirus in the feces can be identified. For blood tests, you can do CBC uh, to rule out anemia, and then also markers of inflammation like markers of inflammation or increase in white blood cells, which shows that there is an active infection. And then you can also do a blood culture. Other tests can include urinalysis, urine culture, and duodenal aspiration and analyze the contents. For management, there are four major goals on the treatment of diarrhea. One, you have diet, dehydration, prevention or dehydration status, macronutrients and treatment of the cause, and generally keeping hygiene through educating the patients. So in the diet, children with an acute diarrheal illness should eat an age-appropriate diet as soon as they have been dehydrated and are not vomiting. Infants, they can resume their human milk or breastfeeding or formula. For chronic non-specific diarrhea of children, dietary fat and fibers should be increased in the diet, and then food intake should be decreased because they are passing out all these fluids. For other causes of chronic illness, adequate nutrition must be maintained, and then particularly that of fat-soluble vitamins. For rehydration, the standard uh, oral rehydration salt or solution is recommended by World Health Organization because it contains complex carbohydrates, that is 2% of glucose and 50 to 90 milliequivalent per mil of sodium. Other drinks like soda, juices, and all similar drinks should not be used because they have too little sodium and too much carbohydrates, and this can bring about the osmotic effect of the excess carbohydrate, result into additional fluid loss through the diarrhea. ORS is recommended by World Health Organization, like we have said, and it's available worldwide. If a child is also vomiting, small frequent amounts are used, starting with 5 ml every 5 minutes and increasing gradually as tolerated. Generally, in management of dehydration, we use either oral rehydration salt, that's for oral intake, can use normal saline or ringus lactate, that is for intravenous use. Can also give oral rehydration solution for the malnourished, that is for the malnourished children. All of these are readily available. So generally we follow the plan B, plan A and plan C for management of dehydration. For plan A, generally it's prevent dehydration. Therefore, in addition to the normal feeds the child has been taking, you give them 50 to 100 ml per loose motion in case they are less than 2 years. For children more than 2 years, you give 100 to 200 ml per loose motion. The moment they get an episode of diarrhea, give them those meals. That is for individuals that are not dehydrated. Now, for plan B, the individual has some signs of dehydration, like eager to drink, sunken eyes. So what do you do here? You give 75 mils per kilogram in 4 hours. So you get 75, you multiply by the weight of the child. Whatever volume you get in mils, you give it slowly in 4 hours. If the child vomits as you're giving them, you leave the child for 10 minutes and then you continue slowly. And then we go to finally the criteria. See, this is for severe dehydration. The child is unable to drink, they are lethargic, they are unconscious. So here you give 100 ml per kg of ringus lactate, half strength Daros or normal saline. Any of the three can be given. How do you give the 100 ml per kg? For infants less than 1 year, you give 30 ml per kg in 1 hour and then 70 ml per kg in 5 hours. For a child 1 year to 5 years, you give 30 ml per kg in 1 hour, in 30 minutes, and then 70 ml per kg in the next 2.5 hours. As a rule, reassess. After you've finished giving the amount of fluids, reassess 30 to 60 minutes. That is half an hour to 1 hour. After reassessing the state of the child, you reclassify the status of hydration. In case they have moved from one state to another, you also adjust fluids accordingly. We have already finished that part. So for micronutrients, we have talked about reassessing. After 4 hours, you reassess and reclassify. So from micronutrients, you can give folic acid 5 milligrams orally per day, multivitamin syrup 5 mils once a day, zinc 2 milligrams per kg per day, and then copper, that is 0.3 grams per kg per day. For these micronutrients, for example, vitamin A is only given if there are signs of vitamin A deficiency like corneal ulceration or if the child has had history of measles. How do you give vitamin A? You give it at day 1, repeat on day 2, and the last one on day 4. Or we can also give day 1, day 3. I mean day 1, day 1, day 3, and day 14. Let's use this. Give on day 3, day 1, day 3, and day 14. What do you give? For an infant less than 6 months, you give 50,000 international units once a day. For those more than 6 months to 1 year, you give 10,000 international units once a day. Then for those more than 1 year of age, you give 200,000 international units once a day at day 1, day 3, and day 14. If the first dose was given in the referring facility, treat on day 3 and then on day 14. Okay. They came when they have already given, meaning they have gotten the first dose. So you're going to add the second dose and then after you give on day 14. So the treatment of the cause, if the cause is a parasitic infection, give an antiparasitic drug, albendazole, mebendazole, depending. And if the cause is any parenterobacterial infection, choose the antibiotic according to World Health Organization protocol or the established local guidelines that you'll have. And if the cause is of any viral infection, give supportive treatment. If the cause is of any enterobacterial infection, use the following antibiotics. You've seen for cholera, the first line, you can have azithromycin or erythromycin. The second line, you can have cotrimoxazole or doxycycline. For invasive, you can give oral cipro, oral azithromycin, and our broad spectrum antibiotic ceftriaxone is always there. Can give it 50 to 100 milligrams per kg per day. Thank you for listening. I hope you've learned a lot. Enjoy your day and see you in our next lecture.